In this neuromuscular school and conference, we are searching for treatable disorders. Yesterday, we show you the SMA case and how to diagnose. And today, I will present a case. I think we succeeded to reach a diagnosis. So please, every patient you have, try your best to have a final diagnosis. If not, ask your colleagues because it may be a treatable condition and not good to have a patient without treatment. Okay, this patient, Mrs. MAA, she is 44 years old, female patient, married with no special habits of medical importance. Her, her developmental history was uneventful, past history uneventful. Family history, there was no consanguinity between parents and no similar condition. The condition started with gradual onset, progressive course of 4 years duration. The age of onset was 40 years. The condition started with exercise intolerance associated with pains in both knees. The condition progressed and the patient developed bilateral lower limb weakness, proximal more than distal. 1 year later, 1 year ago, so 3 years later, the patient started to walk bilateral unsupported. For me, this is a very uh, rapid condition. Usually, muscular dystrophies is more slow than this. And to start with exercise intolerance, pains, and to experience this weakness rapidly, this is for me not the usual muscular dystrophy I see. Then the patient experienced muscle pains and cramps, especially after exercise. So we usually ask about exercise, about provoking certain foods, about fasting. This is very important. In the last few months, the patient started to experience difficulty in respiration in the form of dyspnea, chest discomfort on any exercise. The patient started to develop upper limb weakness in the form of difficulty in raising her arms. So, a 40 years old female presented with gradual and progressive condition, but started with exercise intolerance, pains, proximal lower limb weakness, then rapidly needs bilateral support during walking, then experience cramps and pains after exercise, and respiratory distress. This is very rapid condition. So all over the history, the patient didn't experience any attacks of seizures, urinary discoloration, especially after exercise, weakness related to certain foods or fasting. So, what I think about this patient, this is not an ordinary limb girdle muscular dystrophy, and there was no consanguinity and no similar condition. Usually, I think about treatable condition before I said this is myopathy, this is muscular dystrophy. This is completely wrong. You must search for patients as if the patient is your relative. I must search for a treatable condition. So I thought about metabolic disorders and I thought about Pompe disease. Think Pompe. Usually, I told you through the, not because the drugs or the company, no, this is a treatable condition. Then, what about inflammatory myopathy? It is a rapid condition with pains and cramps and respiratory distress, very rapid. So I must think about inflammatory myopathy. I thought also about mitochondrial disorders because I saw many patients like this with respiratory distress. And I also put the limb girdle muscular dystrophy. Do you think of any other differential diagnosis you like to add? Hmm. Huh? Endocrinal, yes, yes, I missed this. You are right. endocrinal, especially thyrotoxicosis and hypothyroidismic edema. Yes, I missed this. Others. Usually, when I have pains and weakness, I put osteomyelitic myopathy or marked vitamin D deficiency, and we have more than 150 patients in our department. We diagnose them, but the respiratory distress not occur. But the combination of pains and weakness can occur in osteomyelitic myopathy. So I must add here the endocrinal myopathy and the nutritional myopathy. What I did is I asked for lab. No, sorry, I did the examination first. No cranial nerve affection. Upper limbs showed mild bilateral deltoid weakness, trunk muscle weakness. Lower limbs, there was hypotonia around all joints, bilateral lower limb weakness, proximal more than distal, right equal left, flexors of the hip more than extensors, adductors more than abductors with marked Gower sign. This is very important of taking the adductors and taking the trunk muscle weakness and taking the flexors of the hip, the hamstrings. This is flexor, the iliopsoas, and I missed here. It also takes the hamstrings, the extens sorry, flexors of the hip, the knee, flexors of the knee. There was also flexors of the knee here, the hamstring. So flexors of the hip, the iliopsoas, the adductors, and flexors of the knee, the hamstring, with marked Gower sign. There was no calf pseudohypertrophy. The upper limb tendon, deep tendon reflexes intact, but lost in the lower limbs, and no sensory affection. So I didn't change my differential diagnosis. I asked for the lab. I told you yesterday what is the lab we do. So I did total CK. It was 330 unit per liter, mild elevation of liver enzymes, and she had misleading that C-reactive protein was positive and ANA was positive. And I know through the history that she took steroids full dose with her rheumatologist with no improvement and deterioration of the condition. Serum calcium and vitamin D I did. It was slightly low, 13, and the level must be at least 20 or 30. I missed to do the thyroid function test. I must do here. Nerve conduction study showed no abnormality. EMG, it was myogenic, no resting activity, and decrement test, no abnormality. Echocardiography, no detectable abnormality. The pulmonary function tests showed moderate restriction, ventilatory dysfunction. So there is marked affection here or moderate affection here of pulmonary function test. This is not the usual we have in muscular dystrophy. In limb girdle muscular dystrophy, we wait years until we reach to this condition. MRI muscles, as I told you that we have the protocol since 2017 now, and we found bilateral symmetrical fatty infiltration of both hamstrings. I will show you the hamstrings, adductors of the thighs, all gluteal muscles. What is important is the paraspinal muscles, anterior chest wall muscles, intercostal muscles, and the latissimus dorsi muscles. We have the whole picture, but we choose from every level what is affected, and here the part of the shoulder girdle, upper limbs are okay, but here we can find that starting the paraspinal muscles to be affected, and here the gluteal muscles started. There is fatty infiltration, again. This is the mid-thigh level. This is the hamstrings affected, and also the adductor brevis affected. The leg was completely normal, and here it can give clue to some. We have another doctorate degree in metabolic myopathies in our department, and she do MRI to the patients in her thesis, and usually in diseases like Pompe, the leg muscles is not affected, while the paraspinal and the gluteal are markedly affected, the adductor muscles of the thigh and the hamstrings. This is a pattern. And so the MRI showed us some pattern that give us attention what it can be a Pompe disease. So we have now the facility to do dry blood spot for acid maltase enzyme, acid alpha glucosidase, and we found it positive. It is zero point 0.2 micromole per liter per hour, and this is below the cut-off value. Then we have to confirm this because this is very low level of the enzyme. We did the GEA gene, uh, and we found two heterozygous pathogenic mutation in the GEA gene. And here this is her genetic study. This is two mutations. We found two heterozygous mutations were detected, and we have that the diagnosis of late onset Pompe disease sporadic case. We said it's product, but we must examine the family. We must examine the parents, the brothers and sisters. And what is most important, we must examine also the children, especially if she has a consanguineous marriage. So, what's next to do? I ordered for this patient, I remember the inflammatory panel. But when we have this diagnosis, we didn't do the inflammatory panel. So what is next for this patient? The main assessment at baseline, the functional test is very important because this patient has enzyme replacement therapy. This patient now, through the producing company, we can enter in a humanitarian project and we can order her enzyme replacement. We already started this process because if we didn't do this, this patient will be put on ventilatory support soon. Maybe at this time I will ask for pulmonary rehabilitation. Maybe she will need a BiPAP machine, especially during night. So we asked for enzyme replacement therapy, and also we want to do a family screening, as I already mentioned to you. We must search for her children, for her brothers and sisters to diagnose other patients. Thank you. So we have we can start few questions if you want to ask about this patient or any other patient. I want to explain also that the DBS now is found free in Egypt through the producing company, and if you find a patient positive, they do the genetic test free of charge. So this helped me to diagnose the patients, and we can start enzyme replacement therapy. So we must search for a treatable condition. Any question about this case? It was clear? Okay, Pompe disease, we will have a lecture in the conference. We have infantile onset below 1 year and late onset above 1 year. It could be children, it could be adolescents, it could be adult. This patient started after 40 years. Did you imagine? Okay, so as I usually said, no age is immune. I can found Becker at 10 years, I can found Becker at 70 years. Pains and cramps and exercise intolerance and also fatigue. But this was the starting symptom. I have to examine again. After diagnosis, I have to examine again. And I think after we have these results, maybe we will examine her thoroughly and do the functional assessment to her.
Thank you.
I didn't say, no, they didn't do the MRI of the tongue, but usually Dr. Nermin ask لا لا كملي هو بيقول لك Dr. Nermin usually ask for the tongue but yes we didn't I will check her MRI I have the full but I didn't think that they did for the tongue. Yes, I want. Yes.
The intronic mutation minus 32, 13 TEG.
Which one?
The first. So
the first one?
this is a recurrent mutation that we find in patients. And it's a leaky mutation. So it seems that when the homozygous for this mutation, they have not completely reduced maltase acid activity.
Mm-hmm. But is it enough that we have two heterozygous to diagnose the patient? This is enough for genetic diagnosis because she has no consanguinity. The parents are not consanguineous, and she has two heterozygous mutation. This is enough for diagnosis?
Yeah, this seems enough, but you need to check the segregation to see if these two mutations are in two different alleles.
Okay.
Okay.
So we can take from the
father
parents,
and the mother.
parents
The parents
also.
yeah.
Yes. That's why.
But if you go back to the DBS.
Sorry.
Yeah, so there is a defect.
Yes, markedly low.
Market below.